learning objectives for today's call are to learn about best practices and lessons learned from implementing the immediate postpartum LARC toolkit, finding out about how states are implementing the toolkit, and training providers on how to use them, discovering ways to market and disseminate your toolkit. Our agenda for today, as you can see, we'll have some wonderful speakers who will be speaking with us. From West Virginia, discussing best practices and lessons learned, we have Jenny Hughes. From South Carolina, discussing training and implementation, we have Beezy Gazay and Deborah Billings. And from Indiana, we'll be discussing marketing and dissemination with Velvet Miller. We're really excited to have everyone here. Thank you. Before we get started, I'd like to take a moment to introduce ASTHO to you for all the people who are in the room and will be helping with monitoring the question box. So I'm Ellen Pliska. I'm the Family and Child Health Senior Director, and you've heard me on many previous virtual learning sessions. Next is...
Hi, this is Risha Ranaday. I'm a Senior Analyst on the Maternal and Child Health team.
Hi, this is Sanat Borelli. I'm a Director on the Family and Child Health team.
And this is Nadia Sidki. I'm the Maternal and Child Health Intern here at ASTHO.
Christy?
Good afternoon. This is Christy Mackey. I'm our Chief of Programs for our Community Health and Prevention area, where our Maternal and Child Health portfolio lies.
We're all super excited to have all of you on the call with us today and are looking forward to this. So now I would like to welcome our first speaker from West Virginia, who will discuss best practices and lessons learned from their toolkit development process. Before I turn it over to Jenny Hughes from the West Virginia team, I'd like to remind everyone to please mute your lines. With that, I would like to turn it over to Jenny Hughes. Jenny?
Hi, this is Jenny Yost. I'm an OBGYN in West Virginia. I hope everybody can hear me okay. And I'm going to talk a little bit about our West Virginia experience, how we approach the toolkit and implementation. So we had a little bit of an easier job because we had other toolkits to review and look over. Especially I want to say thank you to South Carolina for use of their toolkit for guidance. But we also really wanted to include a lot of information that was unique to our state. So specifically I want to note we included in background information a discussion of neonatal abstinence syndrome, which is very prevalent in our state, and how potentially by decreasing unintended pregnancy we might have an impact on NAS. We also in our toolkit really wanted to focus on physician champions and really note who the physician champions are in our state. There are 3 academic institutions, and we felt that if we really could get all 3 academic institutions on board, that there would be a trickle-down effect through the rest of the state. The implementation process that we included in our toolkit is really based on one academic institution experience and was successful, and so we used those examples of order sets, procedure notes, patient and supply checklists. We did utilize graphic design for some figures and just to kind of punch up our toolkit, and then we created a billing figure based off communication with each individual West Virginia payer for accuracy. As I mentioned, the implementation process that was included in the toolkit was based off of one institution. However, physician champions from all 3 academic institutions reviewed and edited the toolkit, so they had some input as far as what would work. Those physician champions, along with nursing leaders, have really been instrumental in moving the ball forward, along with the ASTHO team in general, to just kind of keep this process going. And all 3 institutions have been successful in implementing postpartum LARCs. We also, for our toolkit, obtained endorsement from the state section chiefs of ACOG and the AAP. It took us approximately 3 months to create the draft of our toolkit, and then another 2 months to edit it and again make sure it was accurate. Critical resources, again, we used the South Carolina Choose Well Initiative, their toolkit, and then you can see the other resources listed here. Notably, the West Virginia Perinatal Partnership has been very instrumental recently with some billing questions. So in regards to implementation, the first step was just getting everybody together, so convening leadership. This included a roundtable discussion with administration, billing, pharmacy, the head of pharmacy, and then key providers, and essentially just talking about why this is important, what's the value of offering postpartum LARCs, and then talking about kind of the nitty-gritty of, how much about reimbursement, billing procedures, and then, where devices are going to be stored and how that's going to work from the pharmacy. The next step was developing the process for insertion, so identifying patients. How are we going to know what patient wants a LARC and what type? How are we going to consent patients? When is this going to be done? Is this going to be done in the office or on labor and delivery, on the mother-baby unit? What form is used? And then device insertion, developing a supply checklist. This was especially important for Nexplanon. So now we have kind of a Nexplanon kit where you can essentially order your device through pharmacy and then pick up your kit and essentially go off and do your insertion. And then patient education, what documents, what pamphlets, what type of information do we want to hand out to patients for education. The next step was building clinical support. At my institution specifically, myself and a couple other colleagues would meet with the nursing staff. We did this on almost a daily basis until we were sure that all the nurses had received, education about why we're doing postpartum LARCs, what is an IUD, what is a Nexplanon, how do these things work, and what is their role kind of in this process. The next step was really to train clinical staff, and this can be accomplished through a variety of ways, but our institution took this approach via a grand rounds where we essentially invited everybody. All the prenatal care providers, residents, nurses, had a lecture-like format, a lot of kind of Q&A as far as logistics, how things were going to be done, and then we utilized some other resources like the online video that ACOG provides. And step 5 is where we are currently in making adjustments, so reviewing payments received and resolving billing issues. That it's a continuous kind of work in progress. We've had to adjust a few other things along the way, such as supply lists, order sets, things like that, but those are pretty minor. So lessons learned, it does take more than just building it for them to come. This has kind of been a constant, as I mentioned, work in progress. There has been regular communication among the provider champions at each of the institutions, and while there's been success there, as this slide notes, one of our biggest challenges is really recruiting more facilities to implement postpartum LARC. I think that our most useful sections are the implementation section, and then the importance of postpartum LARC in our state, kind of going back to preventing NAS. I think that message really resonates with a lot of people, and so people will champion that cause. Our billing resource, we put a lot of time and effort into kind of contacting each of the payers and just making sure that was accurate, but we found that really that's helpful, but it's going to become even more helpful as we figure out some of the intricacies of inpatient billing. So I think I'm going to conclude there. This is our contact information if anybody has any questions.
Thank you so much. While we're waiting for questions to come in, we would like to open it to the floor for some discussion from our other states. Either South Carolina or Indiana, would you like to add anything about best practices and lessons learned from your experiences?
This is Debbie Billings. Can you hear me? Yeah. I think that the line of it takes more than just building it and they will come is definitely a phrase that we keep saying over and over again. It really requires, once you have the good research that's been put into developing the toolkit, and once you have that, concise document that really can be a guide, that's almost the beginning of the work, right? Because then you've got this really streamlined way of talking about the issues, but then actually going to the different hospitals and such there are a lot of steps in that. And I know when BB and I present, we're going to talk a little bit more about that.
Hi, this is Velvet. I'd like to echo that. It's nice to make a great toolkit. And it's great to feel we've accomplished something, but it goes beyond that, and we've learned that too in many different ways. So I echo what my colleagues have said on the line previously.
Fantastic. We did get a question in the chat box, and that's were the roundtables statewide or at each institution, and were systems similar at each institution, or were there a wide variety even within the 3 academic centers? And certainly the other states could take this as well, but I'd like to open that up to West Virginia first.
So the roundtable discussions were done at each institution. And as far as there's constant communication among the provider champions, but the roundtables were at each institution. And in many of those meetings, there were some representatives from our group that were able to be present. And then similar systems, I would say yes, the systems are very similar in that, when we kind of came up with our toolkit talking about implementation, we did make some tweaks, and that's kind of why it took so long to edit it, is what is actually going to work. The provider champions at the other academic institutions reviewed it to say, okay, is this going to work or not? So I think they're all pretty similar.
Would Indiana or South Carolina like to add anything to that?
Not at this time. Thank you.
Great. What we're going to do is hold the 2 questions that came in for slightly later, because we feel like they may be answered within some of the other presentations. So what we're going to do is thank you so much to West Virginia. We would like to move on to our next presentation, which is South Carolina. We'll be talking about their experiences with Toolkit implementation and training. I would now like to turn over it to B.D. Gazay and Debbie Billings within the South Carolina team.
Thank you, Ellen. It's always a pleasure to get to work with you and your team, and we appreciate the opportunity to talk a little bit more about, in depth, what the South Carolina experience was. I think you'll find, and I just tried to forward my slide, didn't get it, so maybe you guys can forward it for me.
We will forward them for you. Just let us know.
Yes, I just need the first slide up, number 17 on your list. There we go. It might have been up, and I wasn't looking at it up. We have divided ours into just 2 slides. The first talking about our early implementation of LARCs itself and the policy outside the DRG payment, since we were the first state, obviously, out of the gate to do that. And then the second slide will talk more about an update for you as to some of the new programs related to the toolkit that we are rolling out right now. When we started BOI in 2011, in July, we very quickly implemented the policy for reimbursement in 2012. And through 2016, we had limited resources to talk about the actual policy, and that's mostly because BOI has 6 other initiatives going on at the same time. We relied very heavily on our stakeholders. We have about 100 that come to every meeting every month, and they would take the message or information back to their facilities, either their practices or obviously their hospitals, to help us get the word out about what we were doing and the importance of IPP LARC. We have one dedicated staff besides myself here at BOI, which is located, housed at the Department of Health and Human Services. And in 2015, we looked at the 5 highest target volume birthing hospitals, and he went to those sites to promote not just BOI initiatives, but heavily focusing on the LARC IPP and looking to promote the toolkit. We created a webinar in March of 2015 with 3 speakers. It's still online at that site if you'd like to see it. And then probably one of the best strategic moves we made in implementation, was to have a rapid response protocol that we put into place for any emerging obstacles that came up specifically about the LARCs, such as the 2, at least, maybe 3 increases in device reimbursement rates, and also the state sales tax issue, which is big here in South Carolina since these devices do have to have a sales tax applied. This protocol or system helped us protect the momentum that we had built with LARCs at that point, and certainly the launch of the toolkit got to play off of, fortunately, some of the things that we had done from looking at the obstacles to make sure that they were saying the same things in going out for the toolkit that we were. So, Debbie, can I turn it over to you for the next slide?
Yes, absolutely. Thank you. Okay, so I'm the director of an initiative. It's a statewide initiative called Choose Well. So I want to recognize from the outset that Beezy mentioned limited resources up until 2016. We are fortunate in the state of South Carolina to have an initiative that has been able to expand the resources through private funding, a local donor that we have here. And so I just want to recognize that this is not the typical scenario for most states. So I'm going to take you through what we are doing, but then come back to a more typical scenario for states. Because in no way are we saying every state now must go find private funding to implement this. So I want to highlight some of the things that we're doing. Just to also recognize that Choose Well has been a collaborator in the Birth Outcomes Initiative for many years now. So that role that BOI plays in allowing this particular initiative to link with the hospitals and link with other stakeholders has been incredibly important. We, through the initiative, have been able to hire one full-time staff person who is a liaison to hospitals throughout the state and in communication with BOI to really map out what the needs are in the hospitals and define internal champions. I know in the West Virginia presentation you mentioned physician champions, incredibly important. We're also working on nursing champions because of the important role that they play in labor and delivery, and also lactation consultant champions because of the important role that they play and sometimes not delivering necessarily the same message as physicians and nurses are about postpartum LARCs, especially those that contain hormones. What we have been able to do is collaborate and contract with ACOG for them to implement their Postpartum Contraceptive Access Initiative, or PCAI, program. This is the first, it's a brand new program that ACOG has, and this is the first state that they're implementing it in at a statewide level. So that's really important. So we've, in this interaction with ACOG, been able to, I think, really strengthen what they're doing and how they're doing it. And one of the main examples was to come to the conclusion together that hospitals are different. You've got large hospitals, you've got smaller hospitals, you've got geographic differences, population differences, and the level of training and buy-in that different hospitals have really varies across the state. So what ACOG has done in collaboration with all of us is really break down the training into a menu of 6 different options, and I'll tell you what those are in a second. But so that hospitals can do an internal assessment and say, we need options 1 and 3, but the others, we've got those covered. And that's been something that's been important to be able to recognize the expertise of some of the hospitals that are featured in our toolkit, and not say to them, you need to do 1 through 6. Maybe it's just number 2 that you really need to strengthen. Whereas other hospitals that are starting from scratch need 1 through 6, but that's really defined by them. So those 6 modules or the training options are 1, building capacity in general, 2, IPP LARC for clinicians who are doing deliveries, and that includes both Nexplanon and the IUDs, revenue cycle, role of nursing staff, contraceptive counseling, including prenatally, postpartum contraception, and then the last one, sorry, is postpartum contraception and breastfeeding. In 2017, with this kind of configuration, we've been working with 4 hospitals, and that in 2018 will expand to at least 4 more hospitals throughout the state. So we'll keep working with the 4 hospitals from 2017, but then expand to 4 others. So I think it's important to just get back to my initial point that this is not, in terms of the resources that we have available right now for the next few years in South Carolina, this is not the typical scenario. And one of the things that we're emphasizing is with this experience that ACOG will have, we think it will really strengthen their ability to find funding to perhaps then be able to offer this program to other states, and where there might be that sort of ACOG state funding mixture so that it does become more accessible to other states. So I'll just end there and take questions. Beezy and I will take questions now, and then I know at the end of the webinar as well.
Can you hear the phone questions?
We can hear phone questions.
Mm-hmm. Okay, so I'm in Virginia traveling, stuck on I-81, but I'm wondering what the next to the last 6 point of the 6 points was. And by the way, I'm Kathy from Delaware.
It was of the ACOG module. It was contraceptive counseling, which includes incorporating that or making sure that that happens prenatally, and then postpartum contraception and breastfeeding, that combination.
Got it. Thank you so much.
And that's really working with the lactation consultants. Can I just add there that we're working on another toolkit that enables conversations to be started and bridged with lactation consultants, but also lactation consultants with other healthcare providers, so that there is sort of a discussion about the evidence base and the importance of providing consistent messaging to women while recognizing the expertise of lactation consultants and their important roles.
Great, thank you.
And before we open it up to the other presenters to also give their takes on this, we do have some clarifying questions as well. And then they are, was there a formal assessment for the menu of training options?
I'll just answer that quickly. So Choose Well was launched in February of this year, so we're 5 months into the initiative. The menu options were developed about a month and a half ago, so we're really just starting this. But by the end of the year, we'll have some good information.
Great. And then someone else has asked, can South Carolina provide more detail on the rapid response protocol? What form did it take? Was it, for example, an e-blast to all stakeholders? What was that?
Yes, I'd be glad to do that. It developed because of the work groups who report out at every one of the BOI meetings, where we hear about obstacles that were discussed in the work group or about hassle factors, things that might prohibit the success of any of our initiatives. So when we receive that information from the chair people at the report out, we then take that to our what we call our vision team, which is about 15 or 20 people that are appointed to give us help in how we address this, not just for Medicaid, obviously, but for all payers. Blue Cross Blue Shield is a very large participant in our program, and so when we make changes and discuss what we need to do, it usually falls that they're going to see those obstacles and they're going to see those hassle factors as well. Once we discuss that among the group, then in our case, because this is housed at HHS, the first step after the discussion is for me to report back to the director of Medicaid to discuss possible rate changes, just like we discussed reimbursement. We then involve the director of pharmacy is at the table to see if we can make the changes based on what our rebates are, et cetera. But the biggest probably is the Medicaid director saying, yes, I will consider this as part of the budget. Fortunately for us, we have always gotten a positive response, but I think that's because of the energy that we have with BOI, but it's also because we do things in a very collaborative way. And when we talk about what is best for the entire group and what we're doing to, to put a protocol in place, then that just falls right into our being able to talk about it, take action about it. We do keep that response team small for a reason, but that's what's been effective for us. So I hope that helps.
Thank you so much. What we're going to do is open it up to Indiana and West Virginia to see if they would like to add anything before we get to more questions.
This is Velvet. Once again, South Carolina has kicked the ball further down the road and teaching us things, so thank you.
I would agree. I don't have anything else to add at this time.
Thank you. So we do have a couple of questions from the learning community participants, and they're both around clinicians or providers. And so how did you conduct ongoing communications with your provider champions, and is this included communications between institutions? I'm assuming that's along with the training. And then has there been any issues with doing immediate postpartum IUD trainings among clinicians, especially in non-academic institutions?
Debbie, I'll pick up a little bit on that, and then you can add regarding the communication to our champions. It was so valuable for our champions to have attended and be a part of BOI, because they bought into it, and then they would go to their hospital, and I can quote one here in Columbia at one of the largest birthing centers, who went back and told her entire staff on L&D, we're going to do this. So you just each come to the table and figure out how we're going to make this happen. Of course, that also then went to the higher level of the CEO, who had already signed, agreed in a pledge that they were going to help us look at promoting anything that was helping maternal-child health outcomes. The second part that I would address is that we use our peer-to-peer influence through education and not through a stick or threats to other hospitals who might be slow in picking up the policy. So we rely on those champions to pick up the phone, which they are more than happy to do, or meet in person to have a chat to assure other potential champions that this can work and it has worked for them. We are started about 12 now hospitals that actually have the policy. Of course, that's up from 0. And we're looking at probably a 500% growth, I think, in the number of patients benefiting from this service just in 3 years, fiscal year 13 through 16. So it has been effective very much with the champions. Debbie, do you have anything to add?
Yeah, I'll just say that, for some who are listening, they might say, okay, well, you said 12 hospitals, but Debbie's saying 4 to start with and 4, in the next year. And just to be clear, what we mean by that is 12 hospitals have implemented the Medicaid policy. What we're trying to do in a complementary way through this funding that we have through Choose Well is to deepen and strengthen, right, that all of the components, which are all outlined in the toolkit, of implementing that policy, so that it really is something that the entire, staff that are relevant to implementing it are aware of it, are bought in, are excited about it, and that even with staff turnover, that process is sustainable, that service is sustainable over time. So, and the toolkit has really provided the guide for, again, what ACOG is going in and training on. So all of this is very, very consistent. In terms of champions, we're also able to bring people together. This hasn't happened yet, but some of the ideas are, creating sort of short-lived work groups or just spaces where people can get together and share their experiences, share their ideas. Again, in collaboration with BOI, maybe formally recognizing the champions and celebrating their successes. And then I would end with BOI has a fantastic symposium at the end of every year, and we'll be doing a session in that symposium, and certainly inviting the physician champions to be there and to be collaborating and contributing to that conversation.
Thanks so much. With that, I think we are going to move on. We'd like to thank the South Carolina team for their great presentation, and now we would like to turn it over to our speakers from Indiana. We'll be talking about toolkit marketing and dissemination. Dr. Velvet Miller and Dr. Tracy Wilkinson, please take it away.
Okay, this is Velvet, and I'll start. It's an easy button, so thanks, South Carolina. You made it easy for us as you outlined strategies to keep in mind in marketing and disseminating. And we really continue to learn from you with all that you raise in each time we meet you or hear of your efforts in South Carolina. So thanks again from all of us. The marketing and dissemination issues were broken down into three major questions. And the first one was, what's your process for disseminating, and what did you consider? Well, once again, you think everybody. So we just need to get it out to everybody. But we took it seriously enough to go through the series of questions that are essential as you look at how far wide, whom do you want to target. So again, what are the key resources for providers? Do they read? Is it conferences? Is it small group meetings? Who are the key resources for women regarding birth control? Because that we found is also really important as we put out the word that this service is available to everyone. And is it friends and family? Is it bedsider.org? What are the resources for women? Where do they get their information? Who are the key influencers? And then who can help increase awareness in the community? There's some that are obvious. There's some that are not obvious. And we decided to think seriously about where we can get the biggest bang and where we can tap unused sources or underutilized resources to help us. What we really had in thinking through this were a lot of network weavers that sat around the table and thought about this. So each person, and in our subcommittee there were probably 8 members, each of us had multiple networks that we worked in, spoke to, and could go back to and say, help us think more about this. So the second question was, who was our intended audience for the toolkit? Again, everybody, that's obvious, except we tried seriously to break it down, and we think, again, this is what we learned from our peers in the network through ASTHO. So certainly we knew we needed to get to OBGYN providers. We have had a lot of success in working with family medicine providers because they are key influencers and or providers of LARCs. Our pediatricians, based again on their national policy statement about this being first-line reference for adolescents. Certainly our nurses, being one I thought they're key, and group practices. Then you move to the hospitals, the organizations, community organizations, state and local health agencies, etc. We were also very keen on having the insurance industry at the table, both the statewide agencies and the private insurers. Now, what helped us with this was the fact that we were a subcommittee of our Indiana Perinatal Quality Improvement Collaborative. We were the group that worked on the toolkit and the plan for marketing and dissemination was a part of the education subcommittee. Now, just as a context, because I think everyone has perinatal improvement collaboratives within their state, or most do, but ours represents about, there are about 200 members on it, and it represents folk from every major organization in the state that reflect the targets that we said we wanted to get to, including the ACOG, including key churches that were socially active, including the Anthem Insurance Company, the Latino Institute, the Indiana Rural Health Association. We, working with the IPQIC, as we call them, helped us tremendously, because that group of folk who are very active, very diverse, and represent a very wide, comprehensive membership had the responsibility of helping to get this word out. This was their initiative. We were a subcommittee. We referred things to them, and they, being led by the Commissioner of Health, Dr. Jerome Adams, who, by the way, just got confirmed as the U.S. Surgeon General, plug. But that group was the major statewide organizations, key stakeholders, key influencers, and early adopters. All of them were committed to helping to make sure this word got out to throughout the state. So we had champions, and we held them accountable, and to our surprise and joy, they really did push the initiative in their organizations. What we also were not surprised with is some were far more aggressive, far more engaged than others, and that takes me to the next step. What did we learn? Well, the old adage of when you fall down, make it part of your dance. So you don't say, oops, and now what do I do? You just say, okay, so here's what we learned, and here's how we can learn from that misstep and keep on dancing. We've learned that we were extremely ambitious and made lots of assumptions. We learned that the follow-through and the continuing to work the plan is something that must be done. You can't stop with just putting it out there. You can't even stop with the first wave of activities. It needs to continue, and we've misstepped there, so we're going to get back up and start dancing again. We've learned, and this was shared by our South Carolina colleagues, that it really does take some dedicated staff, folk that are really OCD and really can keep us on track to get things done. As I look back on our challenges and our assignments, I thought, oh, I was supposed to do that a month ago. And then I thought, okay, I better get back up on the horse and keep on rolling. We also realized there were things that we did not think of or found as new opportunities, meaning we can burrow deeper into the networks. We can do more weaving. We did not include the issue of coercion or reproductive justice, and we hope to raise that so that any revisions we do in the future will include that. We are humbled. We know we have more to do. We're excited because there have been many that have done extraordinary work throughout the implementation. However, what we know is that we also need a better tracking system of who's doing what. So our marketing and dissemination, we continue to learn. We continue to realize we may have made a stumble, but we're still dancing. So we're not done yet, and we're happy to answer any questions you may have.
Thank you so much, Velvet. While we're waiting for additional questions to come in, we'd like to open it up to South Carolina and West Virginia to add anything about marketing and dissemination.
Well, I would like to add, first, Velvet, thank you for so many great things you're saying about South Carolina. We really do appreciate it. We can never hear enough since we work hard like you guys do too. But just to say that to complement our dissemination of not just the toolkit, but also the policy, we actually have access to an 18-wheeler simulation lab. It's called the Sim Coach. We partner with one of the largest hospitals in the state, Palmetto Health, to utilize this. And even though the primary purpose for it was to, and still is, to visit all of the 44 birthing hospitals on site to provide simulation training to their staff and try to address C-section rates and now maternal hemorrhage, we also have a Mama U and an artificial arm that looks real, just like the mannequin Lucy does, that if there's time, we have been able to utilize LARC insertion by the MFM that is leading the training. So that's just been an asset for us in getting this out and about. Thank you.
Thanks. Would West Virginia like to add anything?
Well, just to say, first of all, that's amazing as far as the truck that's going around. That's amazing. But we have our toolkit on a multitude of websites that are available for people, and have just, right now we're really at the beginning stages of really disseminating the toolkit. So we've learned a lot really just from hearing how the other states are going about things.
Thanks. We do have one question, and that's about funding for marketing and dissemination of the toolkit. Could any of these three states answer a little bit about where the funding came from, or if they had funding in order to do this?
This is Velvet. I'll take the first part of that. The answer is quick. No, we did not. And could we use it? Yes, we could. Would it have helped us expand this? Yes, as long as we also had good tracking information and systems in place. So having the funding would be very helpful.
And Debbie, if you would like to answer for South Carolina about your approximately $8,000 contribution to the development of the toolkit.
Yeah. So again, depending on, we depended on some private dollars from a private foundation, but really in the end, from start to finish, it was about $8,000. And I think part of that was engaging graduate students who are really interested in this work. And so they got something out of it, as part of their degree, and were able to conduct the interviews and really draft the text. And
it's really hard to hear.
Oh, sorry. I thought I had the microphone up to my mouth. I'm so sorry. So what I was saying is it cost about approximately $8,000, and one of the big things was engaging graduate students in public health who were able to use this as part of their learning experience, and they were really committed to this project. So that was exciting. So the big cost was really around the design and the graphic design and layout. And then we printed a certain number, but we really are depending on the electronic version because printing costs are high.
This is Jenny from West Virginia. We don't have any funding, and again, just to echo what South Carolina said, we have really relied on the electronic version and housed it on a variety of websites for that reason, just because printing is expensive.
And we do have one final question about marketing and dissemination. That is there a recommended realistic number of hospitals in a given year or other time period of adoption of the immediate postpartum LARC process, and that they understand that that may vary depending on state or jurisdiction? So if you could answer that, that would be great.
I'll take that just as a front runner in saying that we were hoping that when we predicted the number that would come on early, which we thought once it got rolling, everybody was going to pick it up. And what happened was if one person had a bad experience at a hospital, mostly from administrative side, they would then tell another hospital that it was a bad story, they weren't going to get reimbursed. So for us, we tried to make a goal in BOI to increase the number of LARC hospitals in one given year by threefold. So we didn't want to just double it, we wanted to triple it. And we did not achieve that. We did get close to it, but we did learn there's just actually no way of knowing what the uptake is going to be, even if you've got great champions, because, again, it's not just a champion that has to make the process work. Thanks.
Yeah, this is Debbie from South Carolina. I mean, I think what I'm going to say isn't surprising to anyone. I think like any innovative program, it requires that follow-up time to help people figure out solutions to some of the glitches that they're facing. And like BZ said, the glitches for the most part are not coming from the physicians or the nurses and the actual, the interaction with the patients and actually providing the services. It's really around those technicalities of billing and reimbursement and those processes. And so it really, I don't think this is any different from any other innovative program where we can put a lot of great ideas out there and even tools, but if we don't develop some mechanisms where there's the ability to follow up, and even if that's, I don't know, a hotline or something where people can pick up the phone and say, I'm banging my head against the wall, I can't figure this out, and we're able to help them figure it out, then things tend to go back to, the usual way of working.
This is Jenny from West Virginia. I totally agree with everything you just said. It's taken us a while just to have 3 institutions on board, and we were really hoping for that trickle-down effect. And really, the barrier right now is figuring out the glitches with inpatient billing, and we are working on it diligently. And I think our billing resource is going to just continue to be improved as we kind of figure out kind of those kinks in the system. But once we have better tangible evidence of exactly how the different payers work to really hand over to other facilities, I think that's a barrier for us right now.
This is Velvet in Indiana, and while we did not put a number target for our hospital implementation, we realized early on that Indiana is one of the lowest uptakers of LARCs, period. So although we can step back and say, now let's really focus on this particular group or that particular group, we knew we had to make our community more aware, our broad community more aware of LARCs. We knew we had to work with our organizations so that the fear of any kind of coercion or genocide thoughts were obviated and dealt with early. We have not met with a lot of resistance on that end, but we have not targeted the hospitals as in terms of numbers. They are included in our broader sweep of marketing.
Thank you for that comment, everyone. And Velvet, that nicely segues us into the more open discussion and answer question. And as you know, many of the participants were prompted during the registration process to ask their questions for all of us about toolkits. And so we compiled those questions, and we'll be using some of them to guide this open group discussion. And one of those questions was, how has each state considered addressing reproductive justice in toolkits? And we did also get a chat-in question about what are the best practices regarding patient counseling to avoid coercion, and how is that addressed within your toolkits? And so would any of the other states like to answer that?
Ellen, I'll make a statement about coercion. We did not hear that when we were developing the policy and the toolkit, which was good. However, we did hear it from a lot of other states as we talked in guidance about what would you say to this. So our comment has been that it doesn't matter which insurance card the mom shows up with, if it's private, if it's a Medicaid card, it is still always her choice. It is not something that a policy is going to direct. It is what the mom thinks is best for her. Thanks.
And this is Tracy DeLapp from West Virginia. I just wanted to add that we've run into this quite a bit because we've been trying to partner LARC services with harm reduction entities. And what we've been running into, and I'm sure the other states have this problem too, is that the women that are attending like the needle exchange programs where contraception is offered or being discussed are so impaired they're not able to give consent. So that we definitely have that high on our radar, and we are very cognizant of that.
We also have
no, you go ahead.
Well, I just wanted to add, this is Jenny from West Virginia. We also do have wording in our toolkit about essentially offering all forms of contraception. And again, it's the patient's choice as far as what works best for her or what she would like.
And this is Debbie from South Carolina, and that is constantly the message that we're also sharing among all the sites, among partners, just in the work that all of us are doing every day. I'll just say that there is a section in our toolkit about the importance of prenatal contraceptive counseling, and part of that was to say, when we talk about the Medicaid policy, it's focusing in on being able to access the actual service, the actual IUD or Nexplanon, which are really expensive. But that can't be separate from what happens in the prenatal period, precisely to address what it is that we're talking about. We didn't think it would necessarily be the most effective way. The audience for the toolkit is a particular audience or audiences, right? They're people working in the hospitals, and we wanted to put it in language that would resonate with them and be sort of a way to guide their practice. And that's the way we framed the wording and the toolkit. But certainly in the writing of it, in the back and the forefront of our minds was considering these particular issues and what do we need to put in as a step-by-step process that ensures that doesn't happen.
This is Velvet. I just want to be a little more blunt about this. In Indiana, and I think across the nation, we know that communities of color, particularly Latina and African American, have high rates of unintended pregnancies. So when we have those women of those populations in front of us, is there evidence of any coercion on the side of trying to reduce the rate of unintended pregnancy, and is that perceived as an effort to control the birth rate of the minority population? So I think if no one's heard that, I think that's great. But I think we should be very aware that could be and could be a part of the community network about why is this agency pushing LARCs. So I just want to lay it out there as directly as I can.
And can I add to that, Velvet? This is Debbie again from South Carolina. We're absolutely, totally agree with your comment. And I think, again, we are so conscientious and conscious of the way in which we're talking about and not that it's just an issue of rhetoric or discourse. It's truly being consistent with, we're talking about LARCs mainly because to date they have been inaccessible to a lot of women, including women in our state who have private insurance. but the IUD or the implant, because they're so expensive, are not necessarily covered under their insurance plan. And so to open up that possibility of accessing highly effective, also highly expensive contraceptives is really important. It is an issue of equal access for all, but that we're never pushing these particular methods. There's an interesting, and we're happy to share these with you, there was an interesting article with a very inflammatory title published in the Charleston newspaper, and some very, very thoughtful responses from researchers and from people working with women of color, basically saying, agreeing that this policy enables, when it's implemented correctly, brings a new service to women who otherwise could not access it. And we can't, if we inflame this so much that in the end those services return to being inaccessible to those women, that's really a problem.
Thank you so much to everyone who responded to the open group questions, as well as all of the wonderful presentations from Indiana, South Carolina, and West Virginia. Thank you so much.